Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello, everyone, and welcome to this episode of the Doc Podcast. Today's episode will be part one of a two-part discussion I'll be having with the amazing Dr. Stacy Ochoa. This is actually a first on the Doc Podcast, as Stacy also has a podcast called the ASAP Pathway Podcast, and she'll be airing this episode on her platform as well. This way, both of our audiences can benefit from the content. For those of you who don't know Stacy, Stacy started her journey in dental sleep medicine 16 years ago when her dad was found to be CPAP intolerant. She took on this journey as a fight to literally save her dad's life. She took all the courses she could, as well as obtained the diplomat status with the American Board of Dental Sleep Medicine, the ABDSM. Stacy was one of the first diplomats in the St. Louis area and has gained the respect of her local sleep physicians and ENTs by working collaboratively and communicating well with her medical colleagues in a much-needed interdisciplinary approach. Today, she is one of the key pediatric airway speakers at the annual North American Dental Sleep Medicine Symposium. She continues to lecture across the country at local clubs and organizations, raising awareness of this treatable and preventable epidemic. She also mentors others on this journey and helps guide dentists on their paths to bring this much-needed intervention into their dental practices. She juggles the roles of mom, dentist, business owner, and pediatric airway warrior, sometimes dropping a ball as we all do, but picking it right back up and juggling away because it's important. Today, in part one, we're going to provide an overview of when and how interceptive orthodontic treatment can be extremely advantageous and transformational. Review the importance of a thorough diagnosis and treatment planning process. Discuss the literature that supports the value of interceptive treatment and dispute some of the articles that oppose it, as well as dispel the notion that docs who perform this treatment are just expanding every kid in an attempt to cure obstructive sleep apnea. In part two, we'll provide more detailed and specific treatment options and suggestions for pediatric patients who suffer from sleep-disordered breathing. Compare slow maxillary expansion to rapid maxillary expansion, discuss expansion of the mandibular arch, and talk about the possibility of using braces and wires instead of traditional methods to expand and develop the arches. We'll also discuss why we believe many orthos are so resistant to this approach to interceptive treatment. So without further ado, I'd like to welcome Stacy to the podcast. Welcome, Stacy.
Thanks for having me, Mike. It's an honor to be on your podcast.
So tell me a little bit more about, it's an amazing story about your passion for airway orthodontics. Tell me a little bit more about that if you could, and how you've gotten to this point.
You know, I really feel like my story is a lot of people's story. I think we all have, we know someone in our family that isn't sleeping or breathing right, and it happened to be my dad. And, you know, he wasn't tolerant of the CPAP that he was on, and the sleep physicians came to me saying, why aren't you making a device for your dad? Your dad can't tolerate a CPAP. We are out of options. You're a dentist. Maybe we punt to you. And I was like, well, I didn't learn this in dental school, and I don't know how to do this.
And
and you know, I think our the trait of the average dentist is, you know, we're type A, we want to do it right, you know, analysis paralysis. So, you know, I just realized I had to help my dad. So I went and started taking a lot of classes and courses, and this was for adult sleep and airway health. And I got my dad into a device, and but then I started seeing all this in my kids, Mike, like, and it's like, as much as I admire and love my dad and want my kids to grow up to be like my dad, I did not want them to grow up and have all the comorbidities my dad battled. And my dad did lose his battle with sleep apnea on Valentine's night. Gosh, going on 7 years ago, which I can't even believe. But that just ignited this passion for, you know what? We got to get to these kids. If somebody could have helped my dad and saw things when he was younger, let's get really honest. You don't just wake up with sleep apnea one day.
Right.
You don't wake up at 40. This started somewhere.
Right.
The trajectory of health changed. So that's my story. I mean, I started with my dad. I'm very grateful that I was able to help my dad as much as I could.
Mm.
And, but yeah, it ignited this whole journey of helping the kids.
Awesome. That's awesome. I appreciate you being open and sharing that. And I think so often our life experiences do contribute to the directions that we go.
Yes, they do. Yes, they do. And I think that makes us even better healthcare providers because we have the life experience and it's not just a topic to us, it means something to us.
Completely agree. I completely agree. For me personally, it's interesting. It's personal for me in ways as well. I know you're mentioning the story with your dad. I had a personal issue with my airway, not sleep apnea per se, but mouth breathing and obstruction of my nasal passageways. And gone through years ago 2 sinus surgeries, and mine was all allergy based. And I had multiple head CTs and just trying to figure out what was going on, multiple rounds of antibiotic and steroid and things to try to decrease the inflammation and really helped me understand that area, the nasal passageways and airway patency more than I ever really would have, or than we learned. We learned the anatomy, obviously, in our formal training, but not really the practicality of what that means in your average patient. So I started looking into things a little differently and had this concept that when these kids came in with narrow arches and constricted arches, they often had presented to me because the chief complaint or the referral from their primary care provider was crowding. But I was looking at these mouths and I just started to notice that, yeah, their tongue didn't have a lot of room. These kids are growing vertically. They're mouth breathers. Their mouths are open. I just started noticing this. And then I started thinking about my own issues and challenges with airway. And it really evolved from there. And it just became this passion where as I started seeing it in kids and learning how to ask the right questions to parents, which we're going to talk about all that, and learning how to perform certain treatments, which we're going to talk about as well. And then with the advent of low dose cone beam CBCT imaging, which I got in my office in 2014, I started really getting a view of these kids' airways and just working with my local ENTs and allergists to be able to create an amazing diagnosis and plan for these young kids that was truly changing their lives and was way more than just straightening teeth. So in that, every case I treated and every time I had a parent tell me I changed the life of their child, it fueled that fire in me more and more and more, and that passion. And so as I got later in my career, I decided I'd always wanted to teach more. I'd been, as you alluded to, I'd been teaching all along, but I really wanted to spend more time teaching. So I decided that the time was right, that I would spend the second half of my career, as I spent the first half building, growing, and running my own practice. I was going to spend the second half teaching others. And I think that offers me a really unique opportunity because I've been there in the trenches. I've been seeing many, many patients in a day and understand the stresses that come with running a practice. But I have also done this live on patients for many, many years. Going back to the early 2000s. So I can speak to it. Another interesting thing is, and when I was trained, we did a lot of extraction of teeth. We didn't get to treat kids real young, which we'll talk more about. And I think that's important to understand kind of the general concept of interceptive treatment and what we're talking about here. It's more than just treating airway. It's not like you're diagnosing airway. And I want you to touch on that in a moment as well. But it's understanding and diagnosing your patient. It's understanding the etiology of what you're seeing. And so often, as I was trained in my training, you see, and it becomes a reactive approach. When you're talking about your dad, you said it so well when you said, by the time that they're apneic and having all these associated comorbidities, you've missed the window to really be able to proactively do it. And medicine is really starting to get that. It's got a long way to go, but
Agreed.
Healthcare needs to become well care. It needs to become proactive care. And they're starting to realize, like, okay, by the time you have a heart attack, it's a little late, right? We should have caught that heart disease 20 years earlier. By the time you have late onset diabetes, it's probably a little late, right? We can manage it, but we should have. Can you treat it? Can you manage it? Of course. Well, it's somewhat analogous to what we're talking about in pediatric airway and interceptive treatment. Could you wait? Yeah, I mean, the young child is probably not going to die from it at that age, right? When they're young and a teenager. So if you wait and don't do it when they're 6 or 7 or earlier or whatever you're going to be doing, and do it at 12 or 13, what's the mortality rate in there? I don't know those numbers, but it's easy to just say, well, we can do it later. But what damage has been done in the interim?
Amen to that. And that's what I want to go over that too today.
Please.
Is diving into why not wait? And within ASAP pathway, I mean, our tagline is because kids can't wait.
Right.
ASAP pathway, because kids can't wait.
Right.
And I think this is where we need to dive into what are we treating here? And etiology. Obstructive sleep apnea is end-stage disease.
Right.
So a child that has OSA, I mean, that's pretty darn sick.
Yep.
But we can get to them before that too, with mouth breathing issues, allergies, snoring. I mean, there's so much research out there supporting that just snoring only leads to neurocognitive deficits. So you mentioned, Mike, okay, well, let's just wait till they're 12, 14, all the lymphoid tissues tend to shrink back.
Right. Yep. Involution.
Okay.
Yep.
So that's the argument, right?
Yep.
So the adenoids shrink and the tonsils shrink.
Yeah, all the time.
And okay, but the brain is pretty much done developing all the neurons it's going to have by 6. So during Dr. Stephen Sheldon, he is one of the most amazing pediatric sleep physicians out of Lurie Children's Hospital in Chicago, has a beautiful presentation on the first 1,000 days of life. And it's just talking about the neural connections and everything that's happening. And he will tell you repeatedly, if you do not fix this by 6, it's broken, and it's broken for good. So we're not talking an AHI diagnosis.
Right.
I am talking neurocognitive deficits. This is what we have to help these kids with. This is where oppositional disorder, ADD, ADHD, those things get hardwired in. And if you wait, it's hardwired for good. And we've got studies by Karen Bonnick, who studied thousands of children that snored, and they had nothing to do with a sleep study. This was snoring and neurocognitive deficits and behavior issues. It is so compelling in this study with Karen Bonnick that the American Academy of Pediatrics decided to put in that every child should be asked if they snore in part of their discussions with their patients now.
Do you find that the pediatricians are doing it?
I think I'm seeing in St. Louis, I have some pediatricians that are definitely much more open to this. They do refer to the sleep physicians.
Okay.
I think there's still that paradigm that has to shift for them to consider, okay, I sent them to the sleep physician. They don't have an OSA diagnosis. Like, again, let's remember, OSA is end-stage disease.
Yeah, talk about that a little more if you would, because that's a big point that I hear all the time from ortho colleagues, and is, you're diagnosing these kids with sleep apnea. No, I'm not. But talk about that, the difference in what the symptoms these kids present with, and I'll add some of my thoughts on it too. But what are your thoughts on the people who say, no, you're just, you're going over your head. This is a medical issue. It's nothing that you should be dealing with in the dental arena until they have a formal sleep study done and diagnosis of obstructive sleep apnea. Okay.
So if you look at the statistics, 3 to 5% of children have an official OSA diagnosis. Now that's could be potentially bigger because we have a lot of undiagnosed kiddos out there.
Right.
But again, that is end stage. That is a significant health condition, and it's rare. Okay. It's rare. And if you do have a child with that, there is plenty of literature supporting that, craniofacial development should be on the table for those children.
Especially, and I'll review some of that in a little bit. Yeah.
Perfect. Because the non-obese child that has OSA is usually a situation of craniofacial development. But let's go back to, say you've got parents in the office, you're seeing a very sick child, tossing, turning, bedwetting, sweating in their sleep, mouth breathing. This kid's not sleeping well. Fragmented sleep. You send him to the sleep physician. The parents go, again, that has its own obstacles, right? Sometimes a high copay, getting parents to go and
the
have
practicality of doing that in a busy life.
The practicality of fitting that in among everything else.
Right.
Not easy. And the American Academy of Sleep Medicine, they understand this. There are going to be changes coming down the pipe on testing children. They do have home sleep testing on the radar. And I think as the technology and improves, they're going to be able to do that kind of testing at home. But for now, the gold standard is the PSG. So you have little Johnny in the chair. He's all over the place. He is, fidgeting, ADHD, circles under the eyes. I mean, he is classic sleep deprived. You send for a sleep study, comes back normal. Study comes back normal, which honestly in children is more times than not. But this kid is not doing well.
Right.
Regardless, Mike, this is where we, as what I believe orthodontists, dentists, are becoming the primary care of the airway. They see us more than they see their pediatricians. And we're the ones seeing the craniofacial changes. If you have CBCT imaging, we're seeing the adenoids. We're seeing this. We're frontline.
Yes.
And it is our responsibility when those children walk in the door, when somebody's child is in your chair, they're not just that parent's responsibility. They are now our responsibility. And we know too much. We know too much to ignore it. And we need to do what orthodontists and dentists are trained to do. And you're going to go into the things that you see. I can't wait to hear more from you about what are you going to see clinically that's going to say, I'm taking action. I don't care what the results are in a PSG. It is my obligation to make more room for this child's tongue, to get them to the ENT, to help them breathe through their nose and change the trajectory of their life. We know that mouth breathing changes growth and development.
Completely. I'll review some of those studies as well. Harvard studies. I'll go into that and talk about that knowledge. And it's such a great point. So many great points, because I think the people who, for whatever reasons, have their own reasons where they oppose this, they kind of fall back on a couple things. Well, there's no literature saying that there's this connection. And I'll address the 2019 AO white paper in a moment. Apparently, they're actually coming out with a revision. Again, they did a revision in 2019. Apparently, there's a revision pending for the next year or so. So I'll be interested to see what comes of that. But I'll talk more about that in a moment. But as you said, we know there's this problem, right? The American Academy of Otolaryngology head and neck surgery. You quoted the numbers for OSA. They kind of take the term sleep disordered breathing, right? And they said that there's a percentage of kids who snore regularly. They estimate around, say, 10%, right? So that ranges from the obstructive apneas you were talking to, right? Which is 3-5% or so, say. But as you said, probably more. These are just the ones that are presenting or getting diagnosed, to frequent loud snoring, right? So that's sleep disordered breathing. So I've really been big that, does it really matter if they have a diagnosis of obstructive sleep apnea? Again, we're talking about young kids, like to adults, and it is different, right? We can't equate the two. There are similarities, there are parallels, but we're talking about young, growing kids. And as you said and alluded to, we are on the front lines of this. The pediatricians aren't taking radiographs on these kids younger. They're not doing the type of workup and diagnostics we are of their dentition. And the studies bear out that so many breathing issues manifest as malocclusion. And you can see so much from the teeth, the tongue space. And then when you're taking cone beams and you can look at the pharyngeal airway, the nasal passageways, you get an idea if they have nasal passageway obstruction, if they have lymphoid tissue obstruction, both, none, and narrow arches, insufficient space for the tongue, restriction of the oropharyngeal region as that tongue falls back, as those arches narrow. We know as the face grows, if they're opening their mouth often, they're stretching those buccinators, they're constricting the width of the growth of the face, it's making them grow more vertically. Anterior open bites can be more prominent. Tongue thrusts can develop more easily. You have all these other things that are sequelae of that original etiology being the way they're breathing. So when you say, when someone says you need to get polysomnography to confirm that this child has obstructive apnea before the orthodontist can really, or general pediatric dentist, if this is something they're doing, can play any role in this, to me, never made sense. I have every right with my training and expertise to diagnose the symptoms of a patient that's not growing properly. Every right. It's what I do all the time.
And it's interesting too, because if you look at the ENT guidelines for when to remove tonsils and adenoids, I mean, it used to be, infection and antibiotic need throughout the year. It's dental malocclusion trumps those.
The ENTs know more about this.
They know more about the exactly. They know. And I really get a lot of referrals from the ENTs.
I did too. I got a significant number. They get it.
They get it.
Yep.
And I wanted to circle back. So this whole OSA thing, and again, obstructive sleep apnea is a diagnosis based off of an algorithm of AHI, which is being challenged right now. I don't see it going away anytime soon, but we know that is the standard right now of how do we know someone has this condition? We have to look at, okay, what's the AHI? Is it above this? Are they desaturating 3%, 4%? So I get it. It's kind of what we have to deal with right now. But there is a problem with the algorithm. And one of the problems is, are we even looking at the right signaling in the pediatric population? So we're utilizing an algorithm that tends to work for obese men. It doesn't really work well for people with dark skin because of the pulse oximetry. It doesn't really work well for thin women because women don't desaturate very much.
Interesting. Correct me if I'm wrong, they developed these standards off of the adult population, right?
Yes.
There's no sets. They extrapolated them to apply to pediatrics, if I'm not mistaken.
Yes. So then they decided, okay, so for pediatrics, the AHI, they just drop everything. So the AHI, if it's over 1, that child has mild OSA. So 1 to 5, then 5 to 10. And so they just, again, everyone's doing the best they can right now. This is the wild, wild west. It really is.
Yep.
Sleep medicine is a new science, and pediatric sleep medicine is a hot topic and an even newer science. But like you said, Mike, we do not need a diagnosis of OSA to do what we need to do as dentists and orthodontists.
I agree.
So we need to go in and set the stage for proper tongue posture, swallowing, function, and
arch
breathing.
Development. Exactly.
Arch development.
To eruption of the teeth. And that's something where in my profession, I face a lot of criticism from people saying, I'll get into some of the studies of people who oppose early and interceptive treatment, period, philosophically, right? That's something that's deeply ingrained in the profession, but they talk about it as in just the teeth. And there's this concept of you can just wait and you don't need to do it. Actually, we can talk about some of them now. So Gianelli, who's one of the main figures, he's since passed, but he's a main figure in our profession, very respected. He was in Boston, and the guy had more profound knowledge of the literature. He forgets more literature than I would remember. So I'm not questioning his knowledge, his expertise. What I'm saying is he had a very strong dogma anti-interceptive treatment. He published on it numerous times. One of his big studies in 95, he was talking about the fact it all came down to the teeth. Okay. So when orthodontists are kind of anti-early treatment, a lot of it originates from an argument of, can you make room for these teeth and get a comparable orthodontic result and aesthetically and functionally if you don't do interceptive treatment and wait? Okay. There's no mention of airway. There's no mention of the growth of the craniofacial complex in these studies. They're literally talking about management of E-space. And if you start in the late mixed dentition for Gianelli, can you preserve that E-space and still fit the teeth in without having to then go extract teeth if you use, say, lower holding arch and headgear in the late mixed dentition, and instead of this interceptive phase when they're young and address and redirect the growth and development, and then maybe a second phase as needed when they're adolescents to get the teeth all aligned and get an ideal occlusion. You could just create one longer phase that starts when they're in their mid to late mixed dentition with some space maintenance and sort of interceptive modalities, and then transition them into brackets and wires. number one, it's horribly inefficient, right? You're okay, great. So now we keep this kid in braces for 3-4 years. You've got, whether it's not full braces, you're still treating them orthodontically for 3 to 4 years at that point, space maintenance and so forth. Number two, which has its own consequences, negative consequences. Number two, it's about more than the teeth. That's the whole point. Is I can argue with you over whether the E-space is sufficient in this patient, or we can add up the measurement of, okay, that gives me 2.5 millimeters aside on the lower, and I've got 4 millimeters of crowding. That's not the point. The point is this child growing incorrectly, and why is there crowding? If it's crowding because they have big teeth and they've got big broad arches and big teeth, then we can have that discussion. Like, does it really?
It's rarely macrodontia. It's not macrodontia.
I had a study that was published in Orthotown in June, excuse me. And we have a follow-up study. Part 2 is coming out in November. And in part 1 in June, I talked about exactly that, the statistics and the data that talk about how often this is macrodontia versus how often this is narrow constricted small arches, right? There's no good literature out there to substantiate that the majority or the preponderance of the time it's due to large teeth. It doesn't exist. It's almost always due to narrow arches. So why are they crowded, and why aren't we talking about that? And then just to finish on that, Orthodontic, who's been well known in our profession out of the Philadelphia area, he's been, I believe, a past president of the AAO. He went so far in an article to basically call out orthodontists and say that anybody who does it's quackery, that they're a quack if you do interceptive treatment. I mean, stop and think about that for a second. Like, okay, you can have your own opinions on this, right? I mean, and he was 93, his came out. You can have your own opinions on this, but when you're publishing in the American Journal of Orthodontics and Dentofacial Orthopedics, that it was called Unorthodox Approaches to Healthcare. Unorthodox approaches to healthcare. So that was what he labeled interceptive orthodontic treatment as. That's an unorthodox approach to healthcare. And he is a highly intelligent, very, very well-published and well thought of orthodontist who's a thought leader in our profession. So and he used the word, quote unquote, quacks. He said that orthodontists who believe in the value of early treatment are quacks. So when you see something that dogmatic, number one, my attitude is if something is ever that dogmatic in any capacity, run, right?
Amen to that.
Like you and I are not saying, and as we've talked before, neither of us has ever said, nor would I ever say, that every patient should have younger treatment, early interceptive treatment, and that going in and treating these kids young fixes every airway problem. That is not at all what we are saying. What we are saying is, in the orthodontic literature, stop looking at it as, can you use the E-space to fit the teeth and avoid extraction if that's going to be your objective? And why the heck are they crowded in the first place? And let's get more towards that paradigm shift towards an early evaluation and proactive approach where medicine is starting to see, right? Why do we have these sleep monitors, and why are we wearing watches and things that monitor and track our heart rate and our blood sugar? Because medicine is waking up to the fact that by the time you have those issues, you are sick. And if we can get you to modify things before you're sick, we can avoid end-stage disease. We have to have the same mentality in orthodontics and in dentistry and look at it and say, I mean, dentistry's gotten it, right? Fluoride, prevent sealants, right? That all is preventative. I mean, what, we're going to wait till they have a cavity because, well, maybe, you can do a pretty good job if you get it before the cavity's too severe. You can probably still fill it and have a good result long-term for that tooth. Okay, fine. Maybe you could. But does that mean you don't seal that tooth when they're younger? What's the difference in that and going in proactively for interceptive treatment?
It's so, I want to circle back to what you said about it's the etiology. So, and I think it's how you and I first met just on social media because we have a common mission. And man, then we just literally, I think we just talked for hours about all of this stuff. It's like, oh my gosh, these conversations have to happen because
some of it was therapeutic for me.
It was so therapeutic. I mean, it was a nice vent session, and it's so nice because when you find someone else that gets it and sees it and is in the trenches. But back to the etiology, with the dispute of early treatment and intervening early. Again, we're looking at apples and oranges. If you're looking at the teeth only as your why, we're going to come to different conclusions. So what is your diagnosis? The teeth aren't the problem most of the time. Like you said, it is not macrodontia.
Nope.
And like I would even venture to say this whole bimax protrusion thing is even being, some of the most attractive people in the world have bimax, what we would call bimax protrusion.
I treatment planned a case with a resident yesterday, and the patient just had fuller lips, right? And I said to him, because they came up, they draw the Ricketts E-plane, and they're looking at their lip protrusion as what we had to do, what I did in residency, and you go through these steps, and by numbers, that patient is protrusive. And I said to the resident, I said, look, people pay a lot. This particular patient is an adolescent. I said, people pay a lot of money
to look
when
this
they're adults
way
to have lips that full. I'm like, you look at the cosmetic industry. I mean, there is a lot of money going into lips right now to getting lips fuller. I'm like, why would we ever want to do something to this child to take their lip support away when we know that as the face ages, the lips go back anyway and get thinner and retrude, and the nose and the chin get more prominent. So again, I didn't mean to interrupt you with that, but it's such a great point to talk about some of the, again, dogmas and theories.
The dogmas. Well, let's get real. Some of the Ceph analysis were based off of one orthodontist 9-year-old white boy's face.
I literally, my lecture to the residents yesterday was on cephs, and I took them through the history of the evolution of cephalometrics and how it evolved. And if you really understand the evolution of cephalometrics, I have one of my courses on the doc website, on the OrthoCoach website, goes into the diagnosis and taking it to these phase 1 patients and talking about cephalometrics and really how they came to be. And when you really stop and think about the fact that people in my profession are still defending that over 3D imaging.
Oh my gosh.
It's interesting.
It is interesting. And people just hold on for dear life. And I think some of it's out of fear. It's fear of change.
Yes.
They're afraid. And you and I have said this, we have both said, if someone starts saying cure, I always say run,
right. No,
no one is saying cure. And if they are, red flags. But I want to go back.
Or if they're saying everyone.
Everyone.
Or
always. Yeah.
Kid,
all these absolutes. Yeah. Like I treat children. I don't treat statistics. I treat the child sitting in my chair and how they present. And it is my responsibility. And I know too much. And there's too much literature supporting. So back to, the dispute against early intervention.
Can I ask you a question about that real quick?
Yeah.
So the point you just made about the fear they have of doing it. And I agree with you. There's fear. And I'll go into in a little bit some of my theories on how orthodontists get down this path. But what do you think about the fact that because practices are very busy, and because especially in orthodontics, and I'm an orthodontist, I'm not indicting my colleagues, but I talk to the residents about this all the time. It is our responsibility to diagnose each patient and not rush through that process to get them into treatment. And I feel like because the younger kids take a little more time, take a little more energy, you have to look at them a little differently. That visit's going to be a little longer. They don't fit within our box in orthodontics of the consult of the 12-year-old who needs braces, right? And I feel like it's an inconvenience to the practice to take the time, because you can't just look at the images in the back room real quick, walk in, hi, I'm Dr. So-and-so, nice to meet you. Great, Johnny's gonna be ready for braces. My treatment coordinator is gonna go through getting them set up and walk out, which sadly is what's happening in a lot of orthodontic offices very often.
Yes.
As opposed to taking that 5 or 10 minutes that you owe the patient and you owe the profession to diagnose and do a full clinical examination. And it take 15 minutes with a younger kiddo? It might. But just because you don't want to do that, and I'm not even saying every orthodontist has to do that. If you don't want to do that and you want to focus on just treat adults, just treat adults. Like do it. What, who am I to say how you should practice? But don't mock and cast stones at those who are seeing something and doing something that you don't want to do or don't know how to do. Just admit that's not my thing. Like, I focus on this. If you want to do that, okay, great. So what do you think that there's anything to that?
I do. I think, gosh, this is so loaded. We could have a 10-part podcast, I think. I swear we might have to extend it past 2 podcasts because, okay, my brain is going 100 miles an hour with things I want to say on that topic, because I feel, and not just I feel, but I think here's the reality of it. It is the model of the typical orthodontic practice. I think there's a discomfort in treating or seeing a 4, 5, 6-year-old, because I don't think there is a behavior management aspect in the orthodontic residencies like our pediatric colleagues, right? So our pediatric colleagues have behavior management as part of, part of their residency.
Yeah.
They're very comfortable treating a small child because it's part
I'm so
of the
glad
residency.
You're saying this. Yes.
So why not incorporate pediatric behavior management within dental schools and orthodontic residencies? And I say this to all my orthodontists in town that I have been taking to lunch for a decade, begging them to see children younger, because here's the reality. As a primary care dentist, I am seeing a mother pregnant, bringing her other kids in to see me. I'm holding that baby. I'm doing dietary counseling with this child and the mother while their baby teeth are forming. I'm watching this child grow in my practice.
Mm-hmm.
I can't not do something.
Mm-hmm.
The primary care dentist has to do something because we are seeing these children. So we want to refer to our orthodontist. It's just we get the pushback because I think they're just not comfortable. And like you said, okay, if you don't want to see them, that's okay. But don't ostracize another healthcare professional that is able to and willing to see them.
Ostracize and mock.
It's
mockery at this point.
And yes, and it's ad hominem attacks.
Yeah.
It is inflammatory. Yep. It is unprofessional. It is embarrassing.
And it exposes their own insecurities, really. At the
it
end of the
really does at the end of the day.
Secure people don't mock other people like that.
They really don't. And honestly, the ones with the arrows in their back right now, they see it. We all see it.
Yeah.
And hopefully
I've got plenty in mind.
Yes.
I'm used to it by now.
I hope if there's anybody listening right now, look, there's a lot of chairs at the table for this conversation to happen respectfully. I've got medical doctors, Mike, calling me, what do I do with these kids? I have sleep physicians. Yes. So I'm not going to look at my medical colleagues and say, okay, you've taken out the adenoids, you've taken out the tonsils. They're on allergy medication. Sorry. Yep. There's some orthodontists out there that really don't feel comfortable with, not happening. It's not happening. And this is why you see so many general dentists doing this, is because we see the children, we see them struggling. The medical doctors are coming to us with wonderful literature and saying, your turn, doc, your turn. And I'm not going to not do the proper thing because, somebody thinks I shouldn't. I mean, sorry, it's just not going to happen. And the rationale, and the rationale is just not, I don't even understand it. It's apples and oranges, Mike. So back to what is the literature saying to support early intervention? There's plenty out there.
Before you go yes. So I will take it a step further. What you said, you are 110% correct that there is a huge lack of education in most dental schools, and for sure in the majority of orthodontic residencies on management of pediatric patients or patient management in general.
Yeah.
I was very blessed to have a guy, Fred Ferguson. Any of you, shout out to Dr. Ferguson, any of you Stony Brook grad, I think he's still there. I think he is running the pediatric pro. I mean, he was amazing. I credit a lot of my ability to treat younger kids to him. He would stop the whole clinic. So we would be in clinic and you would have all of a sudden and we were treating kids with developmental disabilities. And it was really, it really pushed your limits. And he was not big on sedation. He was like, you figure this out, papoose board, you figure out how to do this. And you're a third year dental student. You're like, what in the world am I doing? And he would literally, when something was going on, you'd all of a sudden you'd be working with your patient in the middle of it. He'd be like, stop. Everybody stop. And you're like, oh, you just hoped it wasn't you that was getting this. He would call, come on, everybody come down. He would call everybody in the class down to center around one person's bay. And he would teach them all right, it's so-and-so, tell me what's wrong here. Now you've just left a kid, you could see them still, but that's like lit up a boost. And he was he was so amazing, and he was about tell, show, do, and he was about not being scared of these,
Yes.
how to get. He would teach us, get down on their level, and he'd take a kid who was out of control. We would say he was like the patient whisperer. He would take a kid who was flipping out, and all of a sudden he would get in front of them. He would do all the tricks that go beyond what we're talking about in this podcast, but and all of a sudden this kid within like 30 seconds is like sitting there listening to everything he does. So, and with a bite block in, and we're like,
yeah, like, here, let me help you work on me now. Yes.
And so I was blessed to have that training, and I get a lot weren't if they didn't go through that. So I was willing to treat younger kids. When I went into my residency, just so people out there know this, most residencies, I've taught in multiple of them. I've trained many residents over the years. Most residencies are not treating young kids. And by young, I don't mean 3 or 4. I mean 6, 7, 8, 9.
Yeah, that's shocking to me, Mike.
Not treating them. So what happens is they might see them, they might screen them, but a lot of it has to do with the system, insurance system. A lot of residencies have high percentage of state-funded patients. And so if they're on state funding and government assistance for their healthcare, they use a Saltzman index, which is a kind of historical index that we use. And actually now even private pay plans are using some of this to evaluate the medical necessity. Okay. So some of that came out in the Obamacare plan, medical necessity for ortho. The orthodontist will know what I mean. All of a sudden you had insurance companies telling you had to fill out a Saltzman index for a private pay patient. We're like, wait, I thought this was just for Medicaid. But in the residencies, you have a high percentage of patients who are on a government insurance program, and they require medical necessity to be proven. Well, you can get medical necessity for, say, a severe craniofacial issue for a young child, for a posterior crossbite that affects, I think, like all the teeth basically on one side. You can't get it for just crowding because they only score the permanent teeth. So if you have that 6, 7-year-old whose central incisors have erupted and their laterals are like completely blocked out, right? Narrow V-shaped arch, anterior posterior V-shaped. They might have a high vaulted palate too. Vertical discrepancy. They're going to be severely crowded. And that kid, 6, 7-year-old, is in your chair. Maybe they have a sleep issue.Maybe they have a breathing issue. You're probably not even talking about that. You can't do anything to that child because the insurance won't cover it.
It's so crazy.
What they will cover is when that child has severe crowding in 3, 4, 5 years, they will cover the extractions. They will cover the full ortho. So the system is set up so that orthodontists aren't getting trained on the patient management or treatment or even diagnostics of young kids, which is why you take academicians like Gianelli and these people who are so anti-phase 1, and you see why they're very anti-phase 1, because they don't have even access to it. Remember, their research, their studies, their patient population is in a residency. It's in an ivory tower. They're not in private practice.
No, they're not
in the real world. They're not seeing what you and I are seeing.
But yet they're throwing
that
out
baby of that mom.
No,
they're not.
They're throwing out, though, what they want to be the standard when they're not even seeing the demographic that everyone else is.
It's ignorance. It really is.
But it really is.
And they're protecting themselves. And
I feel like, agreed, they're protecting themselves. And I feel like they're digging their heels in because, look, as humans, we all want to be right. So there's this natural tendency to support what you're currently doing, to justify why you're doing what you're doing. But if we could all just sit around a table and say, you know what, I'm just going to be really honest. Even if this all shakes out in 5 years, that we are helping these kids. And wow, and look, the literature is there for neurocognitive deficits. Ghazal had a study, really interesting study on 13-year-olds that do not snore, right? They're past that lymphoid tissue shrinkage. They're no longer snoring. But the children that snored between 4 and 6, that no longer snore at 13, were all in the bottom third of their class academically. So the neurocognitive deficit, this is Dr. David Ghazal's paper. The year it came out, I can't remember. He just was at Mizzou with pediatric sleep medicine. He's one of the best in the world. He's the one actually just posted a paper on biomarker testing. They're looking at, okay, let's look beyond the AHI. We should be testing maybe more biomarkers in these children.
Yes.
So we're looking at gut health. We're looking at environmental load. We're looking at epigenetics. We're looking at diet. We're looking at so much with these kids, Mike. And if you're thinking, you have to have a sleep study to do what we should be doing, you can go back to papers that are 100 years old that are looking at the primary dentition. These are orthodontists that pushed out papers in 1918 saying we have to look at the why behind a lack of spacing, or God forbid, crowding in baby teeth. You have to look at the etiology of that. Even though it looks like a minor discrepancy. No spacing between baby teeth and spacing between baby teeth. That's a malocclusion, Mike. And you wouldn't look at a child at 4 and 5 who needs glasses, who needs a hearing aid for quality of life, and say, you know what? Why would I make you one now? You're just going to need new glasses every 2 years anyway.
Exactly.
Let's wait till you're 12 or 13 and your head's done growing.
Right.
Then I'm going to get you glasses.
That's such a great analogy.
What kind of life are they going to have?
That's such a good analogy.
You're going to ask me to watch a child suffer. I mean, this is...
And some people might say, oh, that's a little extreme, Stacy. You need to see. Well, you need to sleep too.
You need to breathe.
So and you need to breathe when you sleep.
And you need to sleep.
If you are not breathing and sleeping well, then I love that analogy to vision, because you're missing a huge part of your neurocognitive development as a result. I mean, as adults, we get a couple nights, we have little kids.
Oh, we're train wrecks.
You miss a couple nights of sleep and you feel it, right? And
yes.
Maybe you can catch up on a weekend, or maybe there's a day when you have patients starting later and you can try to get a little sleep. If you are a child who can't breathe, you don't get that reprieve.
You don't, because you're developing
every single night. And I have a podcast that is going to be, by the time this airs, it'll be out. It'll be releasing on October 5th. So when this airs, it'll have been out on the Doc podcast with the parents of a patient, 6-year-old, who I completely transformed this girl's life by detecting an airway issue. She had no issues with her adenoids. I mean, her adenoids were a little bit enlarged, but she went to the ENT before me and didn't diagnose her with anything that the adenoid hypertrophy was severe enough to warrant anything surgically. Nasal passageways, a little bit of congestion, nothing major. He put her on Singulair, trying to get some sort of just shrinking of that tissue. And his research that he followed, he believed you could have some benefits there from an airway perspective. When you hear this parent's story, dad is actually a certified registered nurse anesthetist. Dad would be sitting up with her, holding her in the chin tilt position to try to get her to breathe at night. Nightly, they were doing this for this child. They never told me any of this. But on the cone beam, I detected some airway issues because she was narrow and constricted. They came to me because she had a protrusive incisor and mom was worried about trauma. Nothing to do with airway. And when I started talking to mom and digging deeper into it, and I saw the lack of tongue space, I saw in my cone beam, the oropharyngeal space was very narrow. And I looked at her allergy shiners, right? I looked at the Denny Morgan lines, the lines under the eyes. And as I always say to parents, like, it's okay if some of us have dark circles under our eyes as we're raising the kids, but the kids shouldn't have tired eyes. I started asking mom about her sleep patterns. I started asking mom about her school or behavior or attention span. When you hear mom, I won't spoil it, but when you hear mom and dad talk about what their experience was when I started asking these questions as the orthodontist, and then what happened when I went in and developed her arches, how can you hear a parent talk like this? It's not me. How can you hear a parent talk like this and not be moved by it and not say, well, maybe there's something to it, let alone to have the audacity to mock those who are changing a life like this? Like, if you don't want to do it because you weren't trained in pediatrics enough, if you don't like the fact that you've got to book more time for these consultations, again, I'm not telling you have to do it. But your insecurities to project those onto others who have found a way to change patients' lives and to mock them for it, to me, it does such a disservice to our profession.
It does.
Because you know what, Stacey, at the end of the day, it's a lot easier to take a 13-year-old with crowding and send them to get a lot easier for the provider.
Right.
Send them to get 4 teeth pulled and throw some brackets on and treat that case with braces or Invisalign and straighten their teeth and call it a day. And the last thing you want to do, because like you said, it's very hard to be self-critical. It's very hard to look at yourself and say, maybe I could have done that better, and then change all your office systems and change how you train your staff and change the way you've done it all these years. It's a lot easier to just say, I'm not doing anything wrong. I didn't hurt the airway by doing this. And I want to take a moment to touch on that because
yes,
as I
that's a good
before,
point.
the American Association of Orthodontists came out with this white paper, and they had revised it in March of 2019. And the general sentiment of the white paper was that orthodontists need to defer to their colleagues of their medical colleagues for treatment of and sort of essentially management of obstructive sleep apnea. So the task force essentially was comprised of mainly academicians, but some private practice physicians and orthodontists, but people who are kind of that academic mindset, right? That early treatment really isn't necessarily that beneficial. There were people like James McNamara that have done a lot in early treatment, but not anyone who's crossed that line to have been bold enough to say, well, airway really plays a big role or orthodontics can play a big role in airway management, right? So it kind of self-selected for people who were a little more skeptical of that. And that's my opinion. I don't know these people in and out, but just looking at the names, looking at where they came from and the literature that they were reviewing. They did a huge lit review. And this has been literally the pillar for anybody the past few years has opposed this approach, was to quote this white paper, right? Oh, the white paper. So they couldn't identify any formal OSA guidance for orthodontists. Now, mind you, I said OSA. So as you said, the whole premise of OSA is flawed for children in and of itself. But they were talking about this in terms of obstructive apnea. So what they did instead is they developed specific recommendations that they felt would be useful to an orthodontist in practice. Okay. So I will give them credit. They do a really nice job of laying out airway issues in pediatric patients. They actually do cover a lot of the things we've been talking about in terms of the role airway can play in the growth and development. They also acknowledge, because it's hard not to, that expansion can change the upper airway physiology, which has the potential to improve obstructive apnea, right? Because again, there's tons of literature out there to support the fact that when you expand, you do widen the nasal cavity, you make more room for the tongue, and that you have impacts on the airway.
Yes.
They then amended it to acknowledge in 2019 that sleep disordered breathing could be impacted by interceptive orthodontic treatment. Now, again, that doesn't really get talked about by many people, but they did say that it could be impacted by interceptive treatment. However, their final recommendation was they strongly recommended that the orthodontist perform a clinical risk assessment for OSA and refer at-risk patients to the appropriate physician for definitive diagnosis of OSA, and subsequently, the orthodontist may be involved of the treatment of pediatric OSA. If the treating physician refers the patient back to the orthodontist to address an underlying skeletal discrepancy thought to contribute to the child's OSA.
So you're going to, doctor,
you're going to,
So doctor, let's get this straight. We went to school. We were trained to do, this is our playground. Craniofacial development is not the physicians. And the physicians don't want it to be their playground.
No.
And all the physicians I've worked with over the years, and I've developed a really good relationship with the sleep docs in my town and the ENTs in town. And they're like, look, we're punting this back to you. I mean, they don't know what to look for. It'd be wonderful if they knew how to screen for craniofacial, because man, it would grab a whole population that's not being treated right now.
Thank you. Yes.
You know, so
that never get to our offices completely.
Exactly. That never get to our offices. I would love that collaboration to happen, but it's not happening right now. And the bottom line is we know how to identify the craniofacial issues. And I don't need a diagnosis of an OSA or sleep-related breathing disorder. I don't need a diagnosis to correct what I know needs to be corrected in a malocclusion. I don't.
Well, why don't we have them just define the diagnose the malocclusion while they're at it, right?
Yes, while they're at it, tell us what else you want us to do.
Yeah, and can I work on the open bite? Can I do anything about the crowding? Is that okay, Doc? I mean,
those doctors don't want that responsibility either. So it's interesting that was kind of punted to them.
Yeah,
because the physicians don't want that responsibility, and they'll send it right back to us and say, look, you do you, we'll do us.
Thank you.
And we need to play on this playground together and respect each other. But again, it's back to etiology. It's back to apples and oranges. And you know what, if you're an orthodontist or a dentist or what have you, or pediatric dentist, and you don't want to take the time, you don't want to see a certain population or demographic, That's okay.
It's okay.
And we shouldn't be throwing stones that they don't want to, as long as they refer appropriately and screen.
Correct. Yep.
And then say, okay, this child is mouth breathing, chapped lips, shiners. I'm going to get them to an ENT. And you know what? I don't feel comfortable seeing this 4, 5, 6, 7, 8-year-old, but I know someone in town that does.
Yes. Thank you.
Let's work together and look.
And maybe that practice doesn't like treating comprehensive adult cases that want Invisalign.
Yes.
And so you, and the one that likes to treat younger kids, says, you know, I get a lot of calls for, 50-year-olds with broken down dentition. They're interdisciplinary cases. They don't want braces. They only want Invisalign. And I don't do that much of it. So I'm going to send you to my friend who is an orthodontist who does a ton of that. Like why is that not something in our profession?
Yeah. And it's not a failure that you choose to specialize your practice the way you want.
Not everybody's going to be great at treating a 4-year-old and treating a 40-year-old. It's just,
heck, if I could refer out second molar crowns, I would. But, it's like, there's just things in your practice you're like, not my favorite. And that's okay. Like, but we have to stop the attacks. There's too much literature. There's too much coming out. The physicians are begging for the dental community to be involved. And when we are fighting within our own dental community like this, it is such a ugly wart on our profession. And the physicians are looking at us like, what's your problem?
Hey, get your stuff together. Like I heard that from physicians all the time. Like, why? Well, I sent, mom came, they came to me for their adenoids and tonsils. I heard this from the ENT all the time. I asked if they had been seeing an orthodontist yet. Right. And because I noticed, because the ENTs I worked with now were getting what I was doing, and which we're going to talk about in future episodes.
Yes. So excited.
But they were noticing this. And so they were asking like, hey, has an orthodontist been involved? Yeah. They're just watching them right now. Do you know how many times
I'm watching them be sick?
These people would send, these ENTs would then say, you've got to go see my buddy, Dr. Luke. Like, and they would call me like, I kind of feel bad. And I never wanted to be taking a patient, but they're like, what you said earlier, like, I see there's a problem with this kid. I know you can help them. And so I needed to tell them, like, I think you should get another opinion. And so the parents would come to me, bring the patient, and I would look at the kid, and I would never say anything critical about the other. One of the first things they'd say is, after I went through everything with them and explained what we were going to do to develop the arches, like, why were they doing nothing at the other office? And I would just say, everybody approaches things differently.
Yes.
All of our training is different. I happen to have a real passion for this. I happen to have done a lot of this. And so I see this, and just other people maybe aren't seeing it. And they just kind of have more the traditional approach where you kind of wait and do it a little older. And that's that. Like, I'm not going to sit there and indict my colleague for not doing it, because maybe they don't know about it. Maybe they're not exposed to it.
And let's go to that. Just like not all orthodontists, not all dentists are practicing similarly.
Right.
Same for ENTs, same for sleep physicians.
Completely.
I mean, not all ENTs are super proactive. I mean, finding a ENT that's willing to jump in and work with you. I mean, you're going to have to do some digging in your community and phone calls and finding that ENT to partner with in your community. But I mean, it is, if we to sit and watch and not do anything when we know it's only going to get worse and the child is suffering, it's, to me, with the knowledge I have, it's like supervised neglect for me. I can't do that. So I will go and say, get another. I have had patients get 4 opinions from ENTs in town till they found the ENT that changed their life. You keep fighting. You're the parent. You're the advocate. You keep going. You as the parent have to find the provider that's listening to you. And if you see a glazed look and a sarcasm and a flippant attitude from an orthodontist, you just grab little Johnny and say, thanks for your time. And you go to somebody else. Or like we have on ASAP Pathway, we have a provider list of orthodontists and pediatric dentists and dentists and people like yourself that you can go to. But it's to say that we shouldn't be doing anything and just watching and waiting, it's just not an option. It's not an option. And I just think more conversations like this need to happen, and we have to stop this arrow throwing at each other. And you know what's interesting? Back to, I'm going to wait. Do I have to wait for an OSA diagnosis or lack thereof before I address a malocclusion? No.
Right.
And Audrey Yoon and Stanford's studies that have just been released.
Yeah.
You know what? It was during COVID. There were parents that were not wanting to have surgical intervention at the moment. They weren't comfortable with it.
Yep.
So they had a population of kids that had lymphoid tissue enlargement.
Was that the 2022 in sleep?
Yeah. And they chose to have orthodontic intervention anyway. Like it needs to be done anyway. So let's go ahead and do it first. Because again, it needs to be done anyway. So let's do it now. And, to find the shrinkage of the adenoids by almost 40%, there's nothing wrong with getting started and working.
Absolutely. To that point, I had many ENTs I worked with that, like the patient I was saying, whose parents are on the podcast, they saw a little adenoid enlargement, but they were like, it's not for 6. It's not that bad. It doesn't warrant surgery. Right. So like, go ahead and do your thing. And that's where I learned. And as I did this more and more, I was able to recognize which cases needed to go to the ENT and which didn't. And this was a case where I would say to the parents, she'd already been to the ENT, but let's say this patient I was talking about before with mild to moderately enlarged adenoids, say she hadn't been in the ENT. A lot of those cases, I would do exactly what you just said. I would go in and develop the arches and help grow the arches when they were younger and tell the parents, if we do this and we still don't see resolution in the adenoid size, the airway, the breathing, then we're going to go to the ENT. Because by that point, I didn't do that initially. Initially, I would kind of err on the side of like anything that looked big on adenoids, I would send. And then the ENTs, as we got talking about this, would say like, well, I would learn from them. I'd say, now, I noticed you're not treating these patients or doing anything, intervening in any way, medically or surgically. Do you just want me to go ahead and do my thing first and then see how they respond? And they were like, absolutely.
Yes.
Absolutely. When you know by now, Mike, we know you, we work with you, you know what's extreme and really, you know what I'm going to do surgery on and you know what I'm not in that. And if you're ever, they would say, if you're ever confused, obviously send them, but it's another visit for the patients, for the busy ENTs. Like they don't, it'd be like sending a patient to the oral surgeon because their wisdom teeth are like starting to develop to be like, oh, do you want to look at these for surgery? You know, as a dentist, whether or not that's something that needs to be referred to the surgeon at that point or not. Right. Once you understand the lymphoid tissue, it's the same thing. You start to understand what the surgeon needs to see and what they don't. And so on those cases, I would say, let's just go ahead and do our thing, as you're talking about with Audrey and her colleagues in their Stanford study, and see how they respond. And when I saw that study, I was like, yes, yes, and yes, because I saw that happen all the time.
And let's address evidence-based dentistry. The definition of evidence-based dentistry, it is not just literature. Literature is wonderful. We should be pursuing it. We should be doing these studies. But if we're having more conversations around the dental table, a cup of coffee, talking to our colleagues instead of hiding in our practices behind a computer and attacking each other.
Right.
If we see each other face to face and start showing the patterns that we are seeing within our practices that drive the literature. Let's not forget that. We are doctors. We are helping people. You can't throw out what thousands of healthcare professionals are seeing happening in their practice because a certain study said maybe or maybe not. And, let's even look at how that study was done. And
thank you.
And we can't, there's just so much to learn on this topic.
And you can't really design a randomized control trial for this.
You really can't.
How would you do it? And they know that. The people
they
know it. They know you can't. I mean, retrospective and looking at things retrospectively, sure, you can make some assessments on, which we'll talk more about next time, about whether airway expansion, how it can affect the airway. So you can do some of that because you can look at where they started and where they finished and then take a large sample of patients and see if you can have a comparable result and outcome. But you can't take one patient and treat them early and take the same patient and treat them that has the same parameters. You can't standardize that. No two patients are exactly the same. It's not like you're giving them a medicine that medication is titrated to the microgram of what the dosage is. You can't titrate how the force that you put on every single tooth and on the bone of two separate patients who never present with the same malocclusion, right? You can
control,
take people
right,
who present with the same amount of, say, their blood sugar level, right? You can take a parameter like, okay, you all are within a range of 10 of your fasting glucose level. You can't there's no standards that exist.
Yeah,
like
it's
that.
so hard to quantify this.
You can't quantify it. And they know that.
So hard. And they do.
And
that's
why they're like, there are no data on it. Well, yes, there's tons of research going, like you said, back to the early 1900s showing that you can go in early and help be preventative with your approach to treatment. There are tons of data that show that, and tons of literature out there to prove that you can go in and expand arches and help them grow and help improve airway patency, right? So we know all those things happen. Now, extraction, one thing I want to mention quickly about that. So the AAO white paper also looked at whether or not extraction had a negative impact on airway.
Yes.
This is where it becomes lies, damn lies, and statistics, right?
Yes.
Because what they did is, it depends, as you said, defining your variables and what you're looking for is what's so important. So they compared extraction and non-extraction patients in the permanent dentition to see if you took teeth out on this patient with a similar amount of crowding to patient A, similar amount of crowding to patient B, and you didn't take teeth out on patient B, did patients A and B have different airway outcomes, right? That totally misses the point of whether, if you took patients A and B, or A or B, and started them when they were 6 or 5 or whatever you're going to do, and made room for their teeth and their arches, right? So that broaden their arches, made room for their teeth, so that they didn't have the crowding. Would those patients have different airways at that point? So the point is I'm not saying that just literally the act of pulling teeth ruins airways.
Right.
And there was just recently on one of our social media ortho groups, they were bashing somewhat people who think airway can have an impact, and saying, don't ever extract teeth. You're going to ruin every airway. So, but what the AO white paper gave them sort of the ammunition, because they essentially said that extractions don't have a negative impact on airway, but they didn't acknowledge that if you're not normalizing on either patient, you're likely not normalizing the skeletal relationships. So you miss the opportunity to help them grow and help the craniofacial growth and development. Now they've been sicker, they've been mouth breathing, sleep disorder breathing has existed. And if you pull teeth on one and don't pull teeth on another, are you all of a sudden going to get this miraculously different result? Obviously, on some you are, and some you aren't,
and some you aren't.
And that's going to be, and some's going to have no change. The point is you need to say, what if we treated this kid proactively in, say, the early mixed dentition when they were developing, and help them grow and help make room for the teeth, and now they don't need extraction. So the whole extracting teeth, because I'm telling you right now, the data are also very clear that, and there's another study just came out recently, and I think it was Progress in Orthodontics, that adults with OSA have a much higher incidence, of having a high vaulted narrow palate.
Yes.
So we know that's the case. So if we know that a high vaulted narrow palate is much more common in patients who have obstructive sleep apnea as adults, and we know we can help mitigate that when they're young with interceptive orthodontic treatment, what in the world are we doing?
Exactly.
And how are we defending not doing anything?
If I presented all of my adult sleep apneic patients and the train wreck malocclusions they have, and vaulted palates, it's insane. I'm referring for MSE and MMA, and all of these are craniofacial things that potentially could have been helped when they were kids.
Because they treated the symptom. It's not the extracting the teeth.
Right. It's the
because
underlying.
Extracting the teeth treated the symptom, which was the crowding. It didn't
treat the etiology.
And that's the thing that's missing.
That's the missing piece, friend, is we are apples and oranges. What is your diagnosis? Sit everyone around a table with the same case, and let's see what everyone's treatment plans would be. Well, doctor, what's your diagnosis? What are you treating? Mm-hmm. And then we can say, well, the reason your treatment plan's different than mine is my diagnosis is different than yours.
Exactly. So well said.
And I think too, not only behavior management, but if we can get more studies of more academics of sleep medicine and dental sleep medicine in the dental schools. And I know some on the West Coast, I know there are some ortho programs that I know Stanford is. They're including the study of dental sleep medicine and sleep medicine within the orthodontic program.
Wow, that's great.
Then your diagnosis doctor is going to be different than the average orthodontist diagnosis. When you know more, you do different things.
Yes.
So I think if you're coming at it, I just look at white things. I just look at teeth. The teeth are just the bystander. They're getting shoved all over the place. They're not the etiology. So can we all start being more open to, is there more for us to learn as oral healthcare providers that we're missing, that we need to be more open to the colleagues that do understand sleep fragmentation and the importance of a good night's sleep and proper breathing?
Yeah. And exactly on that note, the article I wrote in June in Orthotown talks about that paradigm shift that needs to occur to stopping, from my profession, so that we need to stop looking at the teeth and centering our treatment plans around the teeth. Yes. The teeth are the symptom. The etiology is the narrowness, the transverse discrepancy, right? And then when you start looking at a patient like that and having those discussions, which is such a great idea, let's get to sit around a table and start talking about why this patient is like that. Instead of, sadly, as I said, in the orthodontic residencies, you kind of ignore anything going on etiologically when that child is in the mixed dentition, primary and mixed dentition, and just worry about cleaning up the symptom when they're an adolescent. That's how they're trained. So if you're not getting the training as you're talking about, thankfully, Stanford and some other residencies sound like they're doing. Yeah, I can see why so many orthodontists come out and are like, this is just, this is quackery. Because the literature you read says that you don't treat any cases interceptively, or very few. If you do, it's a posterior crossbite that you just put an expander in on, because there's not much dispute over fixing a posterior crossbite when the child is younger. So we're talking, I mean, you know how many orthodontists and how much orthodontic literature has come out to say there is no reason to ever treat a patient without a posterior crossbite interceptively. I mean, stop and think. You talk about dogmatic. I mean, wait. So if a posterior crossbite is there, that means the maxilla clearly is narrow.
Yes.
And the mandible probably isn't as narrow, right? Or else it wouldn't have a crossbite. Ever stop and think about the fact that maybe the mandibular arch is even more narrow in the patient without the posterior crossbite?
Well, and Sean Carlson had some beautiful, beautiful study. Yeah, he's great, just on the superior convergence. And when I look at, okay, you're looking at the white things, Doc, I'm looking at the bone. Okay. Mm-hmm. And you can have a skeletal crossbite, posterior crossbite, when you're looking at the Waller Ridge and you're looking at, so we have to look beyond the teeth.
And what you're saying, skeletal, you have a bone crossbite, but not a tooth crossbite, because not of dental compensations. Exactly. Completely.
Yes. Because of dental compensation. So again, what are you looking at and what am I looking at might be two different diagnoses.
And so honestly, most orthodontic residents aren't even being taught to look at it in that light. Honestly, Stacy, they're not. They're looking at these kids younger. They're seeing there's no crossbite. I wasn't. They're seeing there's no crossbite. They're not even taking cone beams. In a lot of residencies, they're still taking 2D imaging and only taking 3D if they see something in 2D, like impacted canines or impacted tooth. They're not even
crazy to me.
That, if you were to take a coronal slice on these patients and just track it back from front to back and look at the bone and the teeth inclination.
Look at that long axis of those first molars.
I mean, you can see so much, and it's like, but no, you can't do anything with that. So it takes people like you and I to keep fighting this fight. And I know we both are going to keep fighting this fight.
We are. We're going to keep educating. And it's really, what's going to take? It's going to take the parents educating themselves and demanding the care they deserve for their kids.
Yep.
This is not rocket science.
No.
I can show a cone beam to a mom in 5 minutes and she's like, duh.
Duh.
The
patient on that podcast I keep referencing, mom is like so passionate about this, and she's told me, she's like, I'll go out with you on the road, like she's so sweet. And at the end of it, we cut filming, and I almost wish she had said it on there because it was so funny. And at the end, we were talking about exactly what you're saying, like doctors aren't doing this, but patients and parents want it, and they can see it once they've been educated and they understand it, and they know that you're right, that this is going on with their kid, and they want this treatment, and they're so happy that they did it, which mom expresses. And then after we cut, she's like, what the heck is wrong with all these doctors out there?
That's what they say to me. They're like, I don't understand. You're showing me and I understand it. And I think it's a mindset, Mike. There's fear involved. There's insecurities involved, and not enough conversation.
Yeah.
And like you and I have said, look, there's plenty of room at the table, because I believe that in the next few years, it's going to shake out that there is something to what we've been doing. And the reason we see it, and I know we'll go into more of that next time, just like how the things we are doing and what we are seeing, and different techniques involved. But friend, I mean, we just have to keep respectfully having conversations.
Yep.
And I no more want to be called a quack for helping a family who gives me a hug and they're like, I got my kiddo. I mean, this is my kid's their best self.
A lot of times in tears.
My kid is their best self. Like nobody does better research than a worried mother. So if you're out there calling other professionals doing this,
my wife would agree on that.
Yeah, exactly. I mean, I'm like, what are you guys doing? Quit slinging mud and let's sit down, and there's a chair for you at the table too. Let's just have some conversations. And I think people would be less disrespectful if we actually talked and looked at each other as human beings and healthcare professionals, and look at your colleagues and say, is there a chance that this doctor is doing this because they want to help that child? And give each other grace and the benefit of the doubt that we actually want to help that child.
And look at yourself and be big enough to be self-critical. I wasn't trained to do it this way. I had amazing training at UConn in biomechanics. And I mean, but like I said, I'm not faulting anyone. The nature of the programs are we didn't treat young kids. I got out and realized almost everybody coming to me was like 7 with crowding and narrow arches. And I'm going, I don't feel good about pulling teeth on these cases because, again, the teeth aren't the problem. And I started doing upper and lower turnkey expanders, and we'll get into more to this next time. But the point is I've done it every different way. And each time I changed from how I was trained in my program to starting to be more aggressive on interceptive treatment was hard, right? It's philosophically hard. I had to be hard on myself, be like, well, geez, the first cases I was starting the first few months, I wasn't doing this. And then as you then, and I evolved there into the way that I had evolved to do the arch wire expansion, I had to be critical of myself all over again and say, well, I've just been doing this for 6 years this way. And that change is hard, and it's humbling. And you have to go to your team and be like, okay, I know we've been doing it this way, but I'm going to change the way we're doing it. And so all those things are little intangibles that I don't think get talked about enough. I think we're very prideful, right? As we are as orthodontists, I know, and I'm dentists in my family. I mean, dentists we're very particular. We're intelligent. We're driven. We're motivated. We're thinkers. We're creative. We have a lot of these things going on. And when someone we also fall into our patterns.
Yes.
And when someone challenges those patterns, when it's working, because like I said, you're not killing people directly when you're extracting teeth, right? It's not like you pull teeth and the patient's dying. When you're not having a negative outcome right away, it's really hard to motivate change, because you can look at that and be like, their teeth, they're class 1, they got a nice smile, their teeth look good. I didn't do anything wrong. And it's really hard to, especially people who've been practicing for a while. And residents are always way more open when I talk about this than practitioners who've been practicing for 30 years, because it's really hard to look at what you've done the past 30 years and go, man, I've messed some people up.
Yikes.
Instead of saying, hey, look, practice is called practice for a reason.
That's right. You know better, you do better.
And
that's
as you know better, I would never fault somebody and say, you should have been doing this 20 years ago. But I do fault somebody for saying, you shouldn't do this today. Like,
amen to that. You know better, you do better.
Yeah.
And it's being humble enough. And we have to, as healthcare practitioners, we have to check our egos at the door for the sake of our patients.
Without a doubt.
And we have to be able to say, how I practice today isn't how I practiced 20 years ago when I got out of dental school. And thank God.
And that's a good thing. Yeah.
That's a good thing, guys. That's a good thing. So I'm looking forward to our next conversation. And like I said, we might have to have like a 10-parter. I don't know when this is going to end.
Maybe monthlies. We'll just throw monthlies in there.
It sounds good to me.
That's great. No, it's been so much fun. I appreciate you having me on yours and being on mine. And it's been great. And I'm really looking forward to next time. We'll dive into some of how we do this.
Yeah.
Get a little more granular on that side of things.
Yeah. Great conversations, friend. This is
awesome.
Good. Thanks,
Same
Mike.
here. Thanks so much, Stacey. All right. Bye.
Bye.
Thank you for watching this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to CE courses or schedule a private one-on-one coaching session with me. And remember to join the Doc community on Locals for more great content designed to help you succeed both personally and professionally. Just go to Locals and search for the Doc community. You can also find Doc on Instagram at @theorthocoach. And remember, you have the power to do amazing things.